I'm Dr. Ken Landau. Thank you for watching. Let's talk about Xarelto or rivaroxaban. This is a medicine that is an anticoagulant. It was first approved in the United States in July of 2011, and it was approved for people undergoing knee or hip replacement surgery to prevent clots from forming in the leg and then potentially going to the lung. In November of that year, 2011, it gained approval for treating atrial fibrillation-related clotting so that you wouldn't develop a blood clot and you wouldn't develop a stroke as long as the heart valve was not responsible for your atrial fibrillation. And then in November of 2012, it was approved for treating and preventing blood clots in the leg that might potentially go to the lung. So this was the first oral factor Xa inhibitor that has to do with the coagulation cascade. Doesn't work on the platelets, it works on the coagulation side of the process. It had already been approved in Europe and in Canada for several years before it got into the United States, and it's a member of what we call the NOAC, N-O-A-C, Novel Oral Anticoagulants. Now, it's not really a blood thinner. It doesn't thin the blood, and it doesn't dissolve blood clots. It helps prevent blood clots from forming, and blood clots that are there don't increase in size. Well, with this drug, there's a problem. And the problem is that the half-life of the drug is short. It gets into your system right away, but it also gets out of your system very quickly. So in an average individual between, say, 20 and 45 years of age, it only is going to have a half-life of about 5 to 9 hours. If you look at older individuals, well, it might extend it to 11 to 13 hours, but nowhere near the entire day. And it's only a once-a-day dose for the average individual. Unfortunately, your factor Xa gets back to normal within the 24 hours. Well, it's important for atrial fibrillation. Atrial fibrillation, about 6 million people in the country. If you have atrial fibrillation, you have a 500% increase in the likelihood that you're going to have a stroke. So you need some kind of medicine. Warfarin's been the traditional choice, but now people are switching over to these novel oral anticoagulants because they're supposedly easy to take, but they're only okay for atrial fibrillation. Remember, if it's not due to a heart valve disease. Now, it's important to realize that it comes in several different strengths. It comes in 10 milligrams that you can take with or without food, but the 15 and the 20 milligram dose you have to take with food. So, okay, now you have non-valvular atrial fibrillation. How do you take the drug? Kidneys work well, 20 milligrams once a day with dinner. Kidneys don't work so well, 15 milligrams once a day with dinner. Kidneys don't work, don't take the drug. And if you're taking the drug periodically, you need to have your kidney function measured by a blood test, simple, readily available, any laboratory. Question is, what happens if you get dehydrated? What happens if you get sick otherwise? What happens if you're in an automobile accident? Well, you might have shock and you might have some damage to your kidney. Something that you have to consider. For deep vein thrombosis and pulmonary emboli, the dose to prevent recurrence is the 15 milligram dose twice a day for 32 days, so a little more than a month, and then you cut back and you take 20 milligrams just once a day. And if we're talking about prophylaxis after surgery, so you're going to have your knee or your hip replacement, have the surgery, then you wait 6 to 10 hours, and then you will take a dose of 10 milligrams once a day. And remember, the 10 milligram dose doesn't matter whether it's with food or without. You're going to take it for 12 days if you have your knee replaced and 35 days if you have your hip replaced. Let's say you're taking warfarin and you want to get off of it, Coumadin, you want to get off of it, and you want to switch over to Xarelto, just wait till the blood test, the INR that's regularly done, is less than 3, and then you can make the switch. The question is, let's say you're taking a blood thinner and now you're going to have some sort of a surgical procedure. Maybe you're going to have some dental work, or maybe you're going to have little minor surgery. Do you have to get off the Xarelto? Typically, the answer is no. However, if it's an important surgery, it's going to be surgery on your eye, surgery on your joint, surgery on your back, you better be off the drug for at least 24 hours, or perhaps even more. Now, anytime you take a blood thinner, these are very finicky drugs, and they interact with a lot of other drugs. So if you're taking an anticoagulant like Xarelto, you better be very careful about taking aspirin or any of its relatives, ibuprofen, naproxen, Shouldn't be taking warfarin or heparin. You have to be careful of Plavix, and even careful of the drugs in the antidepressant family, the SSRIs, the Lexapro and Zoloft and Prozac and Paxil, and even the SNRI, Cymbalta. And it interacts with a variety of other medicines because the other medicines interact with the enzyme that alters the Xarelto, so you have to be careful if you're taking Biaxin, ketoconazole, itraconazole, if you're taking certain HIV medicines, Tegretol, if you're taking phenobarbital, rifampin, or even St. John's wort. Well, most common side effect is bleeding. And you can have some severe internal bleeding, but it appears that you might have a decrease overall in bleeding and a decrease in serious bleeding if you happen to take Xarelto compared to warfarin by just a smidgen. Except for gastrointestinal bleeding, it seems to increase the incidence of GI bleeding. As a matter of fact, in 2015, the Adverse Effects Reporting System of the Food and Drug Administration recorded the serious injury to Xarelto as the #1 drug. After it was approved, it was found that it might be associated with some toxicity that wasn't really understood before it was approved, involving the liver and the kidney. We also know you shouldn't be taking the drug and drinking a lot of alcohol, because if you do, the alcohol interferes with liver function, and the liver is where the clotting factors are made, coagulation factors are made. And it also irritates the lining of the stomach and increases the bleeding from there. Well, if you have unexpected bleeding and you're taking the drug, go see a doctor. Obviously, that makes sense. If you have a bloody nose and it doesn't stop, if you have bloody gums and it doesn't stop, if you have blood in your urine, blood in your bowels, see a doctor. And certainly be very careful if there's anything going on with your spine. You've had spinal surgery, you had a spinal tap, maybe you have an epidural for something, and now you have back pain or tingling or numbness or weakness in your legs or in your feet, and you have loss of bladder, bowel control, better see the doctor right away. And remember, don't take the drug if you have an artificial heart valve. So the study that gained approval for this drug is known as Rocket AF. That's the name they gave it. Rocket AF involved 1,200 different sites in 45 countries. And unfortunately, they have a lot of controversy about this study. One of the areas of controversy is people comparing, of course, the Xarelto to the warfarin, but the people weren't given the correct dose of warfarin. They were only getting the correct dose of warfarin about half of the time. That's not adequate. In Sweden, 75% of the time. India, only 36% of the time. 63% of the time in the United States. And in Eastern European countries, less than 50% of the time were the people correctly monitored and correctly dosed on the warfarin. And the overwhelming majority of patients, if we look at any single area of the world, they came from Eastern Europe. So that's an issue. So 14,000 patients on this study. And what the study did is they looked from the time that these high-risk patients were started on the Xarelto or the warfarin, looked to the time that they would have a stroke or systemic embolization. In other words, a blood clot that spreads typically to the lung or somewhere. Well, it showed quite clearly that there was a benefit to taking Xarelto, a very tiny benefit, but there was a benefit to taking Xarelto, except for gastrointestinal bleeding. So how much of a benefit? Well, if we look at the intention to treat group, and we follow these people for the stroke and the systemic embolization, we find in the people who were taking Xarelto, 2.1% had an event. 2.4% of the people in the warfarin group had an event. That's not all that different. And if we look at the major and minor bleeding, the clinically relevant bleeding, we find that in the Xarelto group and in the warfarin group, they were both about 15%. So no significant difference. If we look at major bleeding, again, no significant difference. If we look at gastrointestinal bleeding, 3.2% in the group taking the Xarelto, 3.2%, versus 2.2%. So it was lower in the people who were taking the warfarin, Fatal bleeding, basically the same. Death, basically the same. Now, several issues. One, when they stopped the study, they took the people off Xarelto. They had strokes. Oh my goodness, they forgot. They forgot one of the simple things. Hey, if you needed the drug while you were on the study, you need the drug after you're off the study. So as a result, there were about 22 people who had stroke after the completion of the study in the group given the Xarelto versus only 6 in the people who were taking the warfarin. And because of that, the Food and Drug Administration said, well, maybe there's a rebound or something like that. So we ought to put a black box warning, making sure that people don't discontinue their drug. Well, unfortunately, you have to continue taking a drug. So that wasn't the issue. There's no rebound. Next issue. The problem is that when the Food and Drug Administration evaluated in 2011 this drug, before it gave them marketing approval, the advisory committee had a big fight. They argued about this trial. They said it was biased towards Xarelto, that people weren't appropriately managed, that if the people were managed right on the Xarelto group, on the warfarin group, that they would have come out much better. They argued about the trial, the execution of the trial, the way it was laid out. And unfortunately, what happened is they licensed the drug, of course. But then a couple years later, at a conference, a journalist for the British Medical Journal, the BMJ, he asked someone from the company, he asked them, hey, wasn't the monitoring device that you used to check the INRs on the group that was receiving the warfarin, wasn't that recalled because it didn't work? So the study was based on a faulty device. Well, that's a major problem. Well, the device was recalled, and actually it was a Class 1 recall. In other words, the Food and Drug Administration said that the device is likely to malfunction, and that malfunction may lead to serious injury or death. And unfortunately, the company evidently had known about it since 2002, and now we're talking about this conference happened to be in 2014. Well, the Food and Drug Administration got news of this, and then there was all sorts of havoc, so that the investigators from Duke wrote a letter to the editor of the New England Journal of Medicine, a very prestigious medical journal. That's where the original article first appeared. And they said that they had reviewed all the information, and yeah, there was some problem, but it wasn't really significant enough to interfere with the results. But as a conclusion of that letter, when people read the letter, people who were in the know said, hey, in order for them to come to this conclusion, there must have been blood tests that they didn't even mention in the original article and they didn't mention in their letter. So now there's a question about, is there some withholding of the data? And that obviously doesn't sound good. So people have been arguing back and forth for a significant period of time. And finally, as an arbiter, Dr. Harlan Krumholtz from Yale University asked the company, hey, just give me the raw data so we can have our people here at the university evaluate the data, the raw data, and see what the story is. And the company said, nope, you can't have it. Well, now there's another problem. And the other problem is, if you happen to be taking warfarin and you start to bleed, we can reverse the bleeding quite quickly with vitamin K. On the other hand, we don't have any antidote at this time for Xarelto or for Eliquis or for Cevisa, for that matter. Now, the FDA some time ago granted breakthrough status to a drug that looked like it might be effective in combating bleeding on these novel oral anticoagulants, except for Pradaxa. That's a separate story. And it's now made by a company called Portola Pharmaceuticals. They've done phase 1, they've done phase 2 evaluations, and they presented phase 3 evaluation to the Food and Drug Administration in August of 2016. And the FDA said, you don't have enough good data. We're giving you what's known as a complete response letter. That means go do some more work and come back and talk to us. But that means right now we don't have anything to combat the bleeding. Okay? Next issue. Next issue is the Food and Drug Administration, the pharmacologist of the Food and Drug Administration, said this is a drug for a 2 times a day dose. The company might want to come out and say and claim that you can take this drug just once a day. Wouldn't that be good? You just take a drug once a day? Everyone wants to take a drug once a day. Well, unfortunately, in the case of Xarelto, once a day doesn't seem to hack it, at least according to the Food and Drug Administration pharmacologist. They said that twice a day is the appropriate dose. Well, unfortunately, it came out, and it's a single dose. But if we look at the novel oral anticoagulants, this is the one that's least likely to be a 1-a-day dose. Now, actually, between the peak and the lowest levels during the course of a day, there's a 17 times difference. In other words, 1,700% difference between the peak level and the lowest level. That's not very good because you got to be anticoagulated for the entire day. So Pradaxa has a half-life of about 12 to 17 hours. You take that twice a day. Eliquis has a half-life of about 12 hours. You take that twice a day. Warfarin has a half-life of 20 to 60 hours. You take that once a day. And you also take Xarelto once a day, and it's got a half-life of 5 hours to 9 hours. Well, that doesn't sound very good. And then there's the issue, do you take aspirin? Well, the doctor says you should take aspirin because aspirin is going to decrease your chance of having a heart attack. Well, if you take aspirin and you're taking Xarelto, you at least double your risk of having significant bleeding. And up to 14% of the people might have significant bleeding over a period of time. And then there are the multiple lawsuits against the drug. So there are at least 18,000 ongoing lawsuits claiming that the doctors and the patients weren't informed that there were bleeding problems with this particular drug. And as an aside, you remember Arnold Palmer used to advertise for this particular drug? He happened to have some cardiovascular problems. He was taking the drug. And remember I said that it caused more gastrointestinal bleeding than warfarin? Well, Arnold Palmer developed gastrointestinal bleeding and had to have surgery, and then ended up, unfortunately, dying shortly thereafter of heart disease. Did the Xarelto have anything to do with it? I don't know. Some people argue that yes, indeed, it may well have. Now, how much does all of this cost you? And the answer is one heck of a lot. If you take Xarelto and if you pay cash for it, you just take your wallet out and you plunk down some dollars, you will need $15 to take 1 day worth of Xarelto. Now, if you have an insurance plan and you go get the copay card, then you could get the drug for a very little amount. But the insurance company is going to pay the tab. And remember, the tab can be as high as $5,000 to $6,000 per year compared to warfarin, and it has a whopping price tag of $50 a year, $4 a month. Now, they're trying to find other indications for Xarelto. They're studying it for heart failure and for coronary artery disease and for peripheral artery disease. And some of those studies are as equally impacted by negative thoughts as the original studies. So the original study is controversial, and some of the studies that they're doing for these other things are controversial. Well, what should you do? That's a tough one. It's a pain in the neck to take warfarin. You've got to go get blood tests relatively frequently, and you have to watch your diet. But it's dirt cheap. It's been around forever. We know pretty much all there is to know about warfarin or Coumadin. Or you could take Xarelto. And if you take Xarelto, we know that there's a lot of confusion about how accurate the studies are. There's question about misleading data. They won't release the data. And it's horribly expensive. $15 a day is the cash price for a drug that minimally impacts on your likelihood of suffering a deep vein clot, a pulmonary embolism, or a stroke in comparison to warfarin. What should you do? Well, let's figure. Now, if it's 10 cents a day out of your pocket or $15 a day out of your pocket, what are you going to do? The issue changes a little bit now, of course, when the insurance company and the pharmaceutical company here take it, doesn't cost you anything. Somebody's paying the bill. Anyway, something for you to think about. I'm Dr. Ken Landau.